Oh, Laurel.
Hmm.
Hi, Laurel.
Now, in a webinar, they will have to submit questions to the chat. They won't be able to talk, right? Yeah.
I can't make it.
That's sort of like they have a goal of the Christmas meal, like just sort of 30. Yeah, I think that 10 minutes, I mean, 10 plus, you know, like whatever you think you can do. Because I'm sure it's also like to ask questions. Sure.
Okay.
Just want to make sure that all the slides are there.
Oh, of course.
And, you know, no, if you just, show the, oh, it looks 65, so I think that.
It should have-
65.
Yeah, they should all be.
Okay, yeah, okay,
If you just want to have a quick look in,
okay. Okay,
right there.
okay,
Oh, sorry, that's okay.
okay, thank you, okay, let's see that. Okay, show them all.
No, it's, yeah, I
Okay, so that's right, okay. Yep, that's it, that's all. Yep, that's right. So we go back to 7. Okay. Hello.
I think it's probably been a few years, maybe 2 or 3 years.
Yeah.
I think so. Yeah, it was pretty active when I was died out. I run fine, right?
But also understand.
The students that dispersed. Yeah. I mean, I feel like for months that they were. So I'm gonna.
No. Thank you. Oh, sorry.
Should I have both of you?
Check, check, check.
I actually.
And your name is?
Connie. I actually can't stay for the event.
Okay, so I'll ask both of you to be right up.
Yeah. Thank you.
Okay, now with the students.
Okay, she's doing well there.
Yeah. Whenever there's a call for the students coming over.
Yeah.
In October. Yeah, it's really, because I think the thing about his race is coming in.
Oh, good. Okay. I work I have an. That's a no. But they feel well.
You know, come to my house, you know, this time, I don't know how long they're gonna be here.
It's not very cooperative.
Oh, there's
Libby also just.
So, questions for do Q&A here.
Yes.
Well, I guess I could.
If it's on the mic, okay, but we'll be trying to pass it on. We'll be trying to pass it on. I think we should probably get started with all of two. Is it being recorded? Yes, okay, great. So it's already on.
Yep, I'll double check. Yep, it is recording.
Okay, great.
Yep,
Great.
no problem.
All right, so folks getting food can get food. Just given that in the interest of time and with our colleagues online, just being mindful of their time, I'm probably gonna get started and introduce if that's okay. Yes.
But a lot of us have to go to MIT at 1, so for like.
Okay. Sure. We understand if folks have to leave. We have like 2 audiences, so always trying to juggle both of them, the needs of both of them. So welcome everybody to the 2024-2025 TUSM Global Health Seminar Series. So this is a series that happens generally every month with support from Tufts Global Health Programs, the Global Health Faculty Council, as well as the Center for Global Public Health at Tufts. And we try and bring a diversity of speakers on a variety of topics, addressing issues around global health equity, work going on globally, and particularly aim to represent, to the extent we can, issues in low and middle income country settings and voices from low and middle income country settings. So I'll introduce in a moment our first speaker of the series, just before I do that, I just want to outline later talks that will happen in the fall. Barry Levy, who's in the Department of Public Health and Community Medicine and is a very prominent health and human rights practitioner, will be talking next month. Ravi Sarkar, who is at I believe, the Public Health Foundation of India, will be speaking on One Health in India later in November. And today we have a wonderful speaker from across campus at Medford. Professor Valencia Kumsen. So Professor Kumsen is in the Department of Electrical and Computer Engineering at Tufts. And she is an associate professor there with a secondary appointment in computer science. She's the founding director of the Advanced Integrated Circuits and Systems Lab at Tufts. She was awarded the George C. Marshall Scholarship to pursue postgraduate studies at the University of Cambridge, where she received her MPhil and PhD in electrical engineering. Her research interest lies in micro and nanoscale circuits and systems, bioelectronics, wearable and point-of-care biomedical devices, and health informatics. She has numerous publications in scientific journals, book chapters, and patents. She was awarded the Dr. Martin Luther King Visiting Professorship at MIT in 2021. She is going to talk today about one dimension of her work, which focuses on mobile technologies and the use for monitoring and implementing interventions for hypertension in Ghana. This is the AHOMKA study, and we're really grateful for Dr. Kumsen being here. Right before you come on, Dr. Kumsen, we have two students, Dan and Connie, who are just going to talk about the Global Health Interest Group at Tufts very quickly, and then we'll have our speaker come up. Thank you, everyone.
Hi everyone. It's good to see some familiar faces. So I'm Dan. I'm a first-year medical student and a fellow with the Center for Global Public Health.
My name is Connie. I'm also an M1. Nice to see you guys.
Yeah, so the two of us are actually reviving the Global Health Interest Group on the Tufts Med campus. So it kind of went inactive a few years back, but we're trying to get it started. And so we have a group me of about 50 members right now. And so if any of you have any interest, at least for the fellow M1s, we sent in the group me, but if there's any other students in here that are interested in getting involved, feel free to talk to me. Connie won't be able to stay for the rest of the event, but I can add you to the group me afterwards. Do you want to talk a little bit about what we want to do?
Yeah, so as we kind of just start up, we're always looking for new ideas and opportunities if other students are interested in certain things. Right now in the fall, we're hoping to host some movie nights about specific topics in public health, including potentially with partners in health as well. And in the spring to host the Global Health Symposium with speakers. Again, if anyone is interested or has more ideas for that, we really welcome that. And we're hoping as well to think about global health conferences and kind of the ability to network with some of our peers at other medical schools as well.
Yeah, so if you have any interest in any of that, just find me after this great speaker event is over, and we'll add you to the group me. So yeah, if you're interested in global health, this is a really great opportunity and a really great community. So yeah, thank you. Without further ado.
Well, thank you, Ram, for the very warm introduction. And it's such a pleasure to be here. It's my first time actually speaking at the School of Medicine in my 19 years at Tufts. So this is a very special event for me. And it's great to see that the students here are getting involved and forming groups around global health. Again, as was mentioned, I'm an associate professor in the Department of Electrical and Computer Engineering at Tufts. And I also hold appointments in computer science and our Data Intensive Studies Center as well. Please feel free to take down my email address. I want to stay in touch with students. I'll present research in my lab, specifically the AHOMKA project. I'll talk a little bit about that project, which is funded by the NIH It's a 5-year grant funded by NIH to look at new models of care for hypertension management in low and middle income countries. But I'll present some of my other research as well throughout the slides. And there will be an opportunity for you to take out your phone and click on a QR code in order to participate in a study that we just got approved for to test out one of our new oximeter devices. So, which is exciting. So I'll go ahead and get started. So today I'm gonna give a little bit of an overview of the kinds of questions we think about in my lab and present some of the work I've done in collaboration with a host of undergraduate students, graduate students, postdoctoral scholars, visiting scientists over the years, and students in the Masters of Public Health program here at Tufts as well, which I've had the opportunity to advise on ALE and ILE projects over the past couple of years. And then trying to answer this question about wearable technology. Can it solve many of the big global health challenges that we face today? And it's still an open question, and it's one in which I hope that we will continue to discuss, and maybe it could be a focus of a topic for the global health student group that's forming here. How do we close health equity gaps? I want to start thinking about that question too. And in that context, I'm going to bring in the AHOMKA project and where are we thinking about going with the AHOMKA project. Again, the context for AHOMKA is in Ghana, which is what I call an emerging economy or emerging country. But the principles and the program goals are equally applicable here in the United States as well. So I want to think about that too. And then I'll conclude. If I have time, I put that research aims in because I have a NIH grant that I would love to collaborate with faculty here at Tufts in the Tufts School of Medicine on. So I'll put a plug in for that too towards the end if there's time. Feel free to please stop me as I'm going along to ask questions. I want this to be as interactive as possible. So please feel free to do that. I want to acknowledge again the amazing students I've had the opportunity to advise. This is just a sampling, so a couple of pictures of them over the years. This is my 20th year actually at Tufts, and I want to acknowledge also my funding sponsors. We've had funding from a host of both federal sponsors like NIH, NSF, DARPA, but also corporate sponsors like Analog Devices, Intel, Bose. We've collaborated with Gap Health and Medtronic. So I'll start here. Does anyone know what this is a picture of? This is typically the first picture I show in our intro to electrical systems course. And I usually ask, you know what this is a picture of? Okay, I see one hand there. Oh, that's a computer, yes. That's a very famous picture of one of the first computers ever built. Does anyone know the name of it? Do you know the name of it? It was called the ENIAC device, ENIAC. It was built by IBM during the World War II era in order to do very intensive computations for missile trajectories and things like that. Now, I did my PhD in the UK, and so they have their claim to fame is another, the first computer, which was built by a BAE Systems, British Aerospace in the UK. So it depends on where you are, who made the first computer. But here we consider the IBM ENIAC to be the first computer. And so it was built in 1946. It was about the size of I would say a 2-bedroom apartment in Boston, 1,800 square feet, maybe 2 or 3 bedrooms. It weighed 30 tons. And it had all of these electrical components. It had a bunch of vacuum tubes in it, which tried to do some electrical amplification, manual switches, thousands of switches, capacitors, resistors, relays in it. It consumed a whopping 160 kilowatts of power, right? And its speed was really, it's infinitesimally low compared to what we can do now. I mean, we're talking about MIPS is what we use as computer engineers to talk about how fast a computer can operate. That's millions of instructions per second. And it costs about $500,000. Now, if we advance a few decades, we have something like a MacBook Pro, which most of you probably have. It has a microchip inside of it, semiconductor microchip. And, it's about the size, we know what the size of these are, it weighs a couple of pounds. It has a bunch of transistors in it. The transistor, a device that's able to amplify current, at very, very low power, which is one of the greatest inventions of the 20th century, is the transistor. The core of your MacBook Pro, there's a small microchip in there that's just a couple of millimeters on each side. And it consumes only about 25 watts of power. And you can see the speed performance. I mean, we're talking about giga instructions per second that it can compute. And you can buy it off the shelf, right? Every day, the average person could get one for about a couple of $1,000s. The core chip in it is probably a couple $100 to manufacture. And so we try to think about, how we've advanced. I mean, it's hard to imagine how we have moved from something like the ENIAC, right, which filled a whole room. You see people walking around inside the first computer, to something you can hold in your hand. And that's really the work of, of advanced manufacturing processes like semiconductor microprocessor technology. And so I would, I'm showing this to say is that, we've seen this enormous amount of movement or change in the way we communicate and we do computation, all because of the invention of this ability to manufacture electrical components at very small scales. How do we transfer the enormous gains we've made in computing for gaming applications, e-commerce, and all this? How do we translate that into the health domain, right? If you see, most health systems are still using things like standard blood pressure cuffs, which we've used for decades. A lot of that technology hasn't changed quite a lot. Can we use this kind of computational power to make advances in health? And I'm focused primarily on preventative health. So my lab here, I was going to show, this is one of the pictures of the first memory chips. I won't go through that because we don't have time. The first hard drive in 1953 had a capacity of a whopping 5 megabytes, right? It weighed about 10,000, it cost about $50,000 for the whole thing. Again, you can buy a Toshiba 5 terabytes, right, for under $100, right? And so what my lab sort of sits at this intersection of semiconductor technology, data science, and biomedicine, right? And what we're trying to, in this picture here is showing someone wearing a watch, for example. And what we want to do is think about, we use Apple Watches for everything, sending emails, texts, watching videos. Can we build devices that can actually predict the onset of an acute event, particularly for patients that are dealing with an acute condition like hypertension or diabetes, or at high risk of stroke or heart attack? Can we build the kind of technology that could help to predict or provide longitudinal data on vital signs, right? That can be used by a clinician to help manage care, help to track disease progression, or, as I said, predict the onset of an acute event weeks or months before it actually happens. And that's really the question, these kinds of questions we try to think about and answer in my group. Why are we talking about this? Well, we know all the headlines about cardiovascular disease is one of the number one causes of death, and high blood pressure being a high risk factor for that. And here are a couple of headlines from the New York Times talking about maternal mortality rates being very high in the United States, and the health disparities by race as well, which always makes headlines. We know the global burden of hypertension. It's estimated that it causes nearly 13% of all deaths worldwide. And 70% is very, very much so in low middle income countries, a high incidence rate of hypertension, which is a major risk factor for cardiovascular disease. We know the economic burden of various non-communicable diseases and the impact that it has on this population in terms of loss in productivity. Cardiovascular disease and mental health conditions are the dominant contributors to global economic burden. And just, some of the remedies to these are taxation, but there's a host of things that can be applied to try to address this issue. There is also the added confounding factor, the added factor that so little of development assistance is allocated to non-communicable diseases. Hence our focus in our research on looking at hypertension and helping a country like Ghana to see how can it manage large numbers of people who are hypertensive and do it in a way that's cost effective, that doesn't require building new hospitals or new infrastructure, and realizing the fact that we're in a country where the patient to provider ratio is somewhere around 10,000 to 1, very high. So are current solutions adequate, right? These are just some basic devices that you can find at Best Buy, which have claims of the ability to track vital signs like heart rate. You know, you have Fitbit, you have, again, Apple Watch. You're all very familiar with these. The Whoop device, which is, marketed as one to help with sleep, to manage your sleep patterns, and helping with things like sleep apnea, and then we have a host of other kinds of digital apps and digital technologies that are being developed. I mean, they're coming out every week, pretty much, new startups in this space to kind of help people manage their health outside of the clinical setting. But are they adequate? And in the context of a low and middle income country, translating these devices into that context, is it a matter of just trying to reduce costs? Is that all we need to do, is make these cheaper so that more people around the world can buy them? And they're very much open questions. Really, how effective have they been even in high income countries like the United States? That's to be determined. And how accurate are these devices, particularly for patients that, have a critical condition where the accuracy of the blood pressure, vital sign and oxygen sat is very critical. Okay. Any questions up to this point? Okay. And another disturbing point here too is pulse oximeter limitations. Now, how many people are aware of FDA safety communications around the pulse oximeter device? Okay, 1 or 2. And I'm assuming we're all medical students. You kind of use a pulse oximeter before. I guess most students have. Pulse oximeters are used to measure how well your body is delivering oxygen to your body. It measures your oxygen saturation. During the height of the pandemic, the FDA issued a safety warning about these devices. And the reason why I kind of focus on pulse oximeter is because many of these devices that you find on the market that are marketed for personal health monitoring rely on the basic underlying techniques of pulse oximetry, right? The use of light signals to measure various biomarkers in the body non-invasively, right? And why is that? Well, it's because optical sources and detectors have become very cheap, from the fact that you have them used in cameras, on your phone, and in all kinds of devices, use very low cost and powerful optical devices in the near infrared region. So it makes embedding that sort of optical sensing technology into a wearable very cost effective. But this safety advisory from the FDA really raises some fundamental concerns about how how technology can be made equitable. Okay, and really, I'll just summarize what it was about. This Dr. Schoding at the University of Michigan, he noticed, he was an ICU doctor, and he noticed that as Black patients were being transferred into his ICU in 2020 during the height of the pandemic, he noticed that their pulse oximeter readings tended to be less accurate than his other patients. And so he measured accuracy by looking at the pulse oximeter reading compared to the arterial blood gas, the gold standard. And as he started to see these errors, and he's mentioned this in some of his talks on open forum, so I feel comfortable sharing that here. He was texting his colleagues about this, and they were trying to figure out what was going on. He has a data science background, so he was able to go to the EHR database at the University of Michigan Hospital, and he started to look at retrospective data on pulse oximeter readings taken within 10 minutes of the arterial blood gas reading. And he noticed that there was a high rate of occult hypoxemia amongst Black patients. And so he defined this condition, occult hypoxemia, as the pulse oximeter reading being above 92%, but the blood gas reading was below 88%, right? And that tended to be 3 times more likely amongst Black patients compared to white patients. And so trying to understand where that was coming from. And one, we know that there are several confounding factors that affect the accuracy of pulse oximeters, one being melanin absorption, right? Melanin also has an extraordinary property that it has a photoprotective property, right? It keeps you from sun damage. And so it blocks light, it absorbs light in the same region of the spectrum that you use for measuring oxygen saturation. So he published his paper, and it prompted the FDA to issue a safety communication saying that doctors and healthcare professionals should be aware that pulse oximeters can be potentially less accurate based on a number of factors, one being melanin concentration, also low blood perfusion, the presence of fingernail polish as well can also cause this error, high BMI, a number of different factors, but melanin absorption being one of the dominant. And so how are pulse oximeters used, and why is that significant? Well, you know, one of the criterion for the use of different COVID-19 therapies was based on the pulse oximeter reading. So this paper here was was a report done on the treatment, this particular COVID-19 therapy during the height of the pandemic. And I just pointed out this one excerpt from this paper. This study was done over a number of different countries, looking at the effectiveness of this treatment during 2020. And it noted the methods used for the study. It said patients were considered to have severe disease if they required mechanical ventilation, if they required supplemental oxygen, and if the oxygen saturation as measured by pulse oximetry was 94% or lower, right? So this had a, so this criterion used the use of pulse oximetry to serve as a threshold on who gets treatment and who doesn't, had a tremendous impact on different populations because of these errors in devices. And so subsequently, there are a number of papers that came out after this, highlighting warnings from the FDA about health risks posed by flawed devices, lawsuits from places like Apple, for Apple Watches, for example, because of their blood oxygen sensor. They use a particular wavelength of light that does not give very deep where you have very high melanin absorption, and you don't get very deep penetration into the tissue. So you actually don't measure arterial oxygen saturation as accurately because of the wavelength of light used in earlier versions of the Apple Watch. So just kind of giving you a sense of the flurry of activity around this particular issue. And so, as I said, many factors affect the accuracy of these devices. This is just a pictorial diagram of a pulse oximeter. You have two light sources typically and a photo detector. You're trying to look at how much light is not being absorbed by various chromophores in the finger. This is an example of the finger. Pulse oximeters can be used in various parts of the body, but this is the most common place. And as I said, we're trying to measure light interaction in the finger. And it can be affected by melanin, it can be by fat tissue, thickness of the tissue. As you age, your skin gets thinner. So the variation in optical properties that can take place from user to user is quite profound and needs to be considered in the design of these devices. So we spent some time in our lab trying to develop a bias-free oximeter device. We have a patent pending on our device. This is just a conceptual diagram of it. We use a number of advanced signal processing techniques and new types of sensors in order to improve the accuracy of these devices for all populations. And our device is being designed to measure not just heart rate and oxygen saturation, which what you typically measure with pulse oximeter, but we want to also actually capture blood pressure. All right. And why is that significant? Because, the photoplethysmogram waveform, which is the basis for the pulse oximeter device, has a rich amount of information in it that is fairly understudied. And what we're trying to do is say, can we build a type of sensor that could possibly measure things like arterial stiffness? Can we measure, again, be able to predict blood pressure using a machine learning model, for example, based on features from that waveform? So that's a little bit about that device. And I'm going to tie this in with the project in Ghana in a moment. But, in addition to that, as we're thinking about building these types of devices that can be predictive and capture data that can be used to detect disease progression, one of our research focuses, and again, I just put this slide here. This could be a whole nother talk. I can come back and give it another time, but talking about AI fairness and algorithmic fairness and ethics in machine learning. And what we're trying to look at here is how well do prediction models, and particularly we're looking at blood pressure prediction models because there's a flurry of research in this area, which is one of the holy grails of blood pressure prediction, is be able to do cuffless blood pressure monitoring. Building machine learning predictive models for doing that is an area of intense research, but not a lot of work is done in looking at how fair or the level of accuracy of these devices, of these algorithms across different subpopulations of race, gender, and age. And that's kind of the focus of my computer science students, my group's research is looking at algorithmic fairness as it relates to blood pressure prediction. Okay, so I just touched on that. If you want to, if you have a question about that, we can talk about it at the end as well. And so here is our oximetry research study for this device here, which we've just developed. We just got an IRB approved to test this device on humans. So if you want to, take down my email address, we're going to be testing at 2 sites, one here at the Sports Library and Tufts Medical Center, and one on the Medford campus. And so you can participate in that study. It's a very 10-minute test. Oh, you have a question? Go ahead. Yes, yes. But well, that's what we're looking at. See, so the underlying signal that's used to measure oxygen saturation is the photoplethysmogram waveform. And that is a waveform that its morphology is dictated by the amount of contraction, the pumping of the heart. And so what we're trying to do is to see like how accurate, right, can we predict blood pressure using this particular waveform? I mean, that's part of the prediction model. Again, a little bit louder. Okay. Yes, that's very true. That's very true. Yes. Oh, for the online audience. Yeah. So she mentioned, is there a minimum sensitivity, right? A minimum threshold by which we can guarantee that we're able to get an accurate blood pressure reading? And that's, and this is what we're trying to investigate, right? So we're looking at various groups. I mean, there are devices on the market that use the PPG waveform on the finger to measure blood pressure. And we're trying to do benchmarking to see how accurate are these devices really on the overall population, particularly subpopulations of age, race, and gender, because the physiology of the heart, right, and the morphology of that waveform that they're using for prediction is based on your demographics, right? And so that's one of the things we're trying to assess, how fair, what's the level of fairness and level of accuracy amongst subpopulations for these algorithms, okay? So you can sign up here for the study. And, again, our vision is, so this is a mock-up of the device on my hand there, is to be able to store data in the cloud, and it could be accessible, right? By hospital, by your physician, anywhere, to be able to track your health. Okay, that's the kind of vision we have for this wearable device technology that's based on pulse oximetry for multi-vital sign monitoring. Okay. And I'll just touch on this too. This is one of the pulse oximeter device is one of the second inventions from our group. Really, the first invention was a new instrument to do cerebral oximetry. I'll just touch on this for it just briefly. So basically taking doing something similar to a pulse oximeter, but for brain tissue, like to measure, the concentrations of oxygenated hemoglobin that's flowing through brain tissue, particularly for preterm infants. And so we're trying to replace this large instrument, large bulky instrument with something that is small and miniaturized that can be more amenable to the form factor of the actual child. And we have a patent for this microchip technology as well that's able to measure tissue optical parameters in a very, very small, you see 1.5 millimeter by 1.5 millimeter chip. So we basically can replace all the signal processing of this large benchtop instrument into something that can be handheld and portable and point of care, right? And so that patent there. Again, I can have another separate talk on this particular technology, so I'll just touch on that here. Okay. And so going to the AHOMKA study, how it fits in. So here, I mean, we started off with the AHOMKA study, looking at ways in which we could enable people to manage their hypertension, at home, in the home setting, outside the clinical setting. Originally, our sensor was to integrate with a mobile app platform so that we could track their blood pressure, be able to store that data in the cloud and be accessible by a clinician at any site that clinician might be found. My co-founder, which I think is here, I think Alice Tang, oh yeah, she's there, hi. Alice Tang is my co-investigator on this grant, and we have a host of collaborators here. Again, this work is funded by NIH, NIBIB, and we're partnering with Beth Israel, as well as the University of Ghana and the University of Health and Allied Sciences in Ghana. And the American College of Cardiology is one of our partners too. And we have industry partners at both at Medtronic Labs and Gap Health. I have their logo on another sheet. And so our goal is, again, thinking about the technology I shared, off the shelf, Fitbit types of devices that we have off the shelf, which don't work kind of well in a different context. But so thinking about how we can develop a technology that can be culturally adapted, right? Culturally adapted is more than just translating it into the local language. It's more thinking about what are the clinical workflows of various hospital clinics in Ghana. How well does cloud stored data fit within the care models that they currently have? What sort of burden do you place on physicians and nurses when you ask them to use a mobile app to track someone's data? And so those are the we did sort of a qualitative study around the use of technology in this context, and then a quantitative study on how well does a mobile platform actually help in helping someone control their blood pressure and keeping their blood pressure in normal range. So I'll just talk a little bit about some of the aims of this program and some of the preliminary outcomes and here, okay. So this is our team in Ghana. This was we have an annual meeting every year. This year it was hosted in the Volta region. And these are some of our team members. And we have our website here. I didn't put it on this page, but ahomka.org is the website for this program too, which you can have a look at. And so in terms of academic institutions, we have 3. 1 here, Tufts, 2 in Ghana. We're looking at the implementation of this technology in 2 different regions of Ghana as well, to kind of understand what are some of the regional differences that need to be accounted for when trying to implement a mobile platform or telehealth platform in this part of the world. Various hospitals, governmental agencies, and of course, private industry. And our funding sponsor, I want to acknowledge. And so what are the core principles? One is user-centered technology design. So we've done studies with both the providers and also patients in order to build our technology. We wanted a high-tech, high-touch model of care, right? So not a model of care where you're completely detached from your from patient to provider, but enabling more meaningful communication between the two, okay? So enhancing communication using mobile technology and not replacing the provider. Evidence-based practices, analyzing social determinants of health. Are there certain aspects of the platform that need to consider the local regional needs of a big global capital like Accra versus more of a quasi-rural area like that's in the northern region of Ghana, which is where our second partner is. And then we're doing both qualitative and quantitative data collection. Here are the 2, this is a little bit about hypertension in Ghana, just to kind of give you an overview of the region. The doctor-patient ratio is about 1 to 10,000. Here, WHO recommendation, so they're well above that. And so definitely a need for ways in which we can help to manage care and reduce burden on staff. High prevalence amongst adults of hypertension, and a low level of awareness. And stroke being the second leading cause of death in that region of the world. Okay. And one of the key motivations for this program was the strong telecommunications infrastructure that we have there in Ghana, right? We have a large, pretty much everyone across the country uses some kind of mobile device, whether it be a smartphone or a basic phone. And most of those users have data plans, right? So they have ability to be able to use apps and store data. and use these tools. We're looking at, again, two different regions, one in Ho, which is in the Volta region, sort of north of Accra, and Accra being the capital region. Again, Ho being more of a quasi-rural, not completely rural, but not as urban as Accra. But again, as you can see, very high coverage of mobile communication across the country. There have been a couple of other studies looking at chronic disease management or non-communicable diseases in the country. This was the ROTEM study. I won't go through this in detail, but people have tried to look at what are some of the environmental factors that affect high rates of hypertension. And so this study looked at different groups of immigrants, both people who lived in a rural part of Ghana, an urban part of Ghana, and then those who were in the diaspora who lived in London, Amsterdam, and Berlin, and looked at higher levels of prevalence of hypertension amongst those who traveled abroad, and trying to assess. So I just want to point this out there. There have been studies that have looked at ways of managing hypertension, some of the social determinants of health issues related to hypertension in Ghana. There have been also other, one of the outcomes of this study was that they looked at 10-year CVD risk was much higher amongst Ghanaian men in urban centers compared to those in rural centers, and they looked at education level and access to healthcare and those kinds of things. There was also another study called the COMHIP study. Again, I'm just pointing these out as anyone's interested in exploring this topic further. This is another project that tried to look at a new model of care, a task-sharing model of care, whereby people can go, increasing access to blood pressure monitoring stations across the country. So allowing people to be able to go to their pharmacist, take their blood pressure, the pharmacist records that data, stores it in the cloud, and then making it accessible to care providers. So this was funded for a couple of years by Novartis. But again, these are kinds of programs that are funded for a couple of years and then kind of just go away. We wanted to kind of do research on a study that could be sustainable, a platform that could be deployed across the region, across a large region of the country, and be very cost effective versus one that's pretty much funded by a drug company wanting to pretty much get data on how their drug is operating across the population. That's pretty much what these studies actually do. They're good studies and they have use, but they're not they don't lead to a sustainable model across the country. So I'll snap through that. I want to kind of get to our study. Our study was based on the use of this. We started off, as you know, with NIH funding, limited amount of funding, but we had a large set of goals we wanted to accomplish. So what's the fastest way to kind of get to the goals we wanted to accomplish? We started off using a platform that was designed by Medtronic Labs. So Medtronic Labs has developed this mobile platform that has a patient-facing app, a provider-facing app that allows clinics in various regions, in various LMICs, to be able to track data on, for hypertensive patients and patients with diabetes on their platform. So they had a platform already ready to go. We just needed to tweak it and adapt it for our particular study. And that seemed to be the most cost-effective approach to take, because all we had to do is pay a few hours of their software engineering team to do the modifications we needed for our particular study. And it worked fairly well. And so we have this platform. There are some pros and cons to it. This is a platform it only runs on an Android platform. So it's not adaptable to folks who are iPhone users. It doesn't allow any kind of text messaging. So if you don't have an Android phone, you can't be a part of the study, right? So it's very limiting in that respect. We try to remedy this issue in the second phase of the program, and I'll talk about that. But I wanted to, again, highlighting some of the limitations of the use of technology that's built in one context and bringing it to another, because most users in a place like Ghana are Android users. And so our technology development, we looked at having personalized care plans integrated into the platform so that at the facility, patient information can be collected in the app against all this data being stored in the cloud, and physicians able to personalize the care plan and treatment plan for patients based on that data. Patients are allowed to monitor their blood pressure at home. So they're given a cuff-based blood pressure monitor for the moment, right? The most accurate one. And they take it home and they're taught, they're trained by the nurse on how to take their blood pressure. According to we use the AHA, American Heart Association standards for home-based monitoring. They input that data into the app. And the physician is able to see it and read it. And the physician can do very detailed reports looking at how your blood pressure is changing over time. The patients are also able to input various symptoms that they're having. If you're dizzy, if you're having problems seeing, or any sort of risk, any sort of symptoms that might be related to something more acute happening, they're able to input that into the app as well as their blood pressure. Okay. And it also has ability for providers to prescribe as well, built into the platform. So we have this provider-facing app that, collects patient information and medical history, and allows the physician to communicate a management plan for the patient. They can see this. I just want to show a couple of the views so you can kind of see what the platform looks like. You can look at longitudinal data of blood pressure recordings. It gives an alert if the blood pressure recording is above a certain threshold, for example, and the physician gets an alert directly to his or her app to show that. Here is showing glucose. We didn't use the glucose feature for this particular part of the study. We just focused on hypertension. You can also, look at patients, how many patients are enrolled in this mobile platform over time, and do various demographic statistics, in the app. And then we have the patient-facing app, right, which allows us to track health. You can input symptoms that you're having. You can, have you been compliant with your medication over the past 3 days, or so. So we can look at medication compliance, and we focus on checking the blood pressure. It also has some data. It also has a few health prompts from the physician built into the app as well. And it has some details on, various health tips that could be useful to help with lifestyle changes around diet and exercise built into the platform as well. So again, wanting to, not only prompt the patients. Most patients aren't used to taking their blood pressure at home. How do you increase use, and also provide information that could help people with lifestyle changes that can have a more lasting impact on them, helping to control their blood pressure. So this was the final, sort of platform optimization and customization that we did, and we implemented this platform. Again, here's some of the other health tips around salt and medication compliance that were built into the platform. And so so once we adapted the platform over about a year's time, our goal was the first aim was to do the adaptation, which we did, and then to do some human subject testing to just test feasibility, right, and acceptability. Okay, so looking at, if we have a cohort of patients using it at both sites, how often do they actually take out their blood pressure cuff and record their blood pressure in 1 week, for example, right? Do you have questions? No, we didn't have a notification feature in this particular implementation. We did not. Yes, because, part of the qualitative, so that's a great question, because, and we went back and forth about it. The part of it, we wanted to first do some qualitative studies about how people actually interact with their phone to measure their health first, because sometimes notifications can get drowned out by the prevalence of text notifications about, other social things. So we wanted to kind of isolate that, maybe in a future study, look at using text notifications, but that is a good point. And so we did this feasibility study on 2 cohorts of patients, both in Accra and Ho, and I'll show a couple of results from that first preliminary study. And in our aim 3, which is later on, we want to see if we can do some predictive risk models based on the data that we've collected. So let me look at, let me go through some of the aims of the qualitative study. So how do we maximize usability and acceptability of the platform? One of the things we wanted to do for this particular study, which was unique to other studies that are being done in the region, is that we wanted people to use their own phone, right? Not to incentivize people to join the program just because we're giving out free phones. We wanted people to use their own phone and be able to interact with their own phone to collect their health data. And so we use this COM-B framework, capability, opportunity, and motivation to kind of ask questions and to assess this behavior change that we're looking to implement with the platform. And so I won't go through each of these due to time, but we try to ask some strategic questions about, do you take your blood pressure at home? Do you understand what the numbers for healthy and unhealthy blood pressure are, and so on and so forth. So we had a series of surveys and questionnaires that we did both at baseline and in line with our patients for this to complete this aim. I want to focus here on motivation. One of the things we wanted to kind of see is what are the beliefs that patients have about bidirectional communication with their provider and how effective it might be with helping them to improve patient care. Because we wanted to kind of tease out what was really the problem with people controlling their blood pressure. Is it just that people are not taking their medication? Or is it more that, they're taking the medication, it takes so long to get an appointment at the clinic, you have to take off work to get up and get a bus, maybe the travel time to get to the clinic might be difficult. So we wanted to really assess, we don't want to assume that just everyone's just not taking their blood pressure medication. We wanted to kind of tease out what are some of the really determining factors around controlling hypertension. And so this is where the cultural adaptation piece came in, because we wanted to really ask the kind of questions that will be helpful in that context. And so we did this sort of assessment. Here are some of the demographic data from the study. I'll just touch on a few of these things because I want to open up some time for questions. I know I'm getting towards a 12:50. We started off, again, this is our first pilot study. We had 16 patients at each study site, a range of educational levels. We looked at some demographic data around employment status, ethnicity, marital status, just to kind of tease out the statistics at both study sites. Some just as a summary to what our baseline and inline assessment showed was that, we saw a large increase in number of people that actually use the platform at least once a week. That was our target, right? Could we get people to use this platform to take their blood pressure at least once a week? And could we get at least 70% of people doing that? And we saw a huge improvement. We saw a huge progression over the 3 months of the pilot study in people actually using their phone to actually track their health, and increasing their knowledge of what hypertension actually is, and what what they call the top number, the bottom number, what that actually means. And also we looked at things like, does the worry about the data costs when using the app on your phone, is that a reason why, would that prevent you from actually using the app? And so looking at some of those numbers as well. So looking at accessibility, looking at overall knowledge about blood pressure, and looking at the motivation for using the platform. We also did focus group discussions with doctors. And so there's a lot of great information that came out of that too, trying to understand how providers will actually interact with this platform. What do they see as being the most effective way to communicate with their patients? And we're still kind of teasing out some of those in-depth focus group discussions that we had with both physicians and nurses in Ghana. Again, most of them were very positive and responsive, but again, thinking about how does the use of this platform affect our overall burdened staff in terms of time, and also how do we deal with the issue of intermittent internet access in the clinic, right? Can we build, so we have our platform actually allows you to at least input data when you're offline, and then it uploads when you're online. So those kind of small features were very critical in motivation of adoption of this platform in our 2 clinical sites. So good. So I just, again, I'm not going to read through all these, in the interest of time, but I wanted to at least end with a look towards the future and what how we've evolved in our platform to date. One of the things we wanted to do is, again, make this platform more accessible to people with different operating systems on their phone, and also the basic phone users. That was very important because you do have a large population of particularly elderly patients who are still using flip phones, right? And we want them to be able to interact with the system. So we added a USSD feature, which we were really excited about. And we're able to, we've adapted the platform using we're using a new software team, Gap Health, which is actually based in Ghana, versus Medtronic, which is, a big multinational company based here in the US. So having a local software developer develop a platform where patients can input their lab results, daily health status, medication adherence. They can do blood pressure and heart rate recordings, do prescriptions and health literacy. And again, main feature, we're now opening up to Android and iOS phones and USSD for text messaging. And so these studies are just starting. Basically enrollment has just started last week, enrolling patients in this study. Again, we're going to have a cohort of 2 users, two cohorts at each site now, 1 smartphone users versus the basic phone users, and trying to assess their level of engagement with the platform. So good. So that's the last thing I wanted to mention here about AHOMKA. We're in year 4 of this 5-year grant, which we're hoping to extend beyond the 5 years. But by year 5, we're hoping to be able to integrate our new ChromaSense device again to be able to interface a API to do Bluetooth connection to the app, and at least record heart rate and oxygen saturation data from our device into the platform. So that will be our sort of year in 5 goal for this program. Any questions? Yes.
What is the?
Oh, okay.
Oh, thank you. Oh, great. Thank you.
With regards to health literacy, what is the program or the app doing about patients? Because mostly elderly patients who don't understand English are the ones with the condition with hypertension. So is their app like in a way or set up in a way that they're easily able to upload this information, like able to understand what it is that they need to upload on there?
Yes, that's a great question. How do we deal with people who don't understand English? And so we relied on our providers at each site. Typically, if you have an elderly patient that doesn't speak English, that person typically has a caregiver. And so we've designed a platform to interface with a caregiver in that instance. We haven't designed it actually to work. And that's a great question. And this is a part of our assessment on how this could be sustainable and implemented across the country. Is we'll need to assess how many people are actually living without, who don't speak English, who would need a platform like this and without a caregiver. Trying to do that assessment. But that's a great point. Yes. Yeah.
Thanks, Ram. I have a follow-up question about the providers. Is this the first time they're using a platform like this? And if so, what has been the adoption rates or approach?
Yes. Yes, thank you. Yes, this is the first time they've used a platform that interfaces with the patient. Now, they have an electronic healthcare record system that they've recently adopted at these 2 clinical sites. But this is unique in the sense that it's interfacing directly with patients. Most of them, said that, if they have a patient that's very high risk, they would give that patient maybe their cell phone number just so they can have more direct access. And that's problematic, as you can imagine, because then the physician is being bombarded, outside of the clinical time with questions from patients. So this platform gives, that bridge, so many of them that, again, I think all the providers that have currently been in our study, this is the first time using a patient, a platform that interfaces with the patient directly. So. And yeah.
One more over here, and I think this will be the last question before we close.
To understand the infrastructural things at Ghana. So this is an app and the whole Ghana is well connected with internet, or how does it work? So does this app have a feature of working when there's low internet or no internet?
Yes, that's a good question. So it has the ability to store, so you can input data. So if you're a patient and your internet connection is just not working well at that moment, you're trying to take your blood pressure, you can input data and it will store it locally on your phone and then upload when your connection comes back on. Right, so there is some offline component there. Now your physician wouldn't be able to read it until it's uploaded. So on the physician side, there'll be some if there is an access issue, that physician would just have to wait until the access issue is resolved, so to read the data. But for storing the data, you can store it locally on the phone and then upload.
Right, I think we're at time, unfortunately. So first of all, I just want to thank you. So that was an amazing tour all the way from ENIAC to the use of technology in low and middle income country settings and very low resource settings where oftentimes it's trying to solve problems that we may not have here in the same way. And what I really loved about it was the way that it interfaced technology with human behavior, with also the human populations, right? That with the example of the pulse oximeter, how even devices that we've been using for decades have are linked with disparate readings, foundationally disparate readings based on skin color. And something that I think that disturbingly was outlined during COVID. So I just want to, if everyone could give a round of applause to Professor Crimson. Thanks. And I don't know if we had any questions from our online audience that we can answer after, but thank you, everyone. So I think we'll bring this seminar to a close. Thanks, everyone.
And I want to say, if you have further questions, please feel free to email me. Okay, please email me.